Okay. Okay, hello everybody, and welcome to Therapy Thursday. My name is Evan Adler. I'm a physical therapist here at UNC Therapy Services, and I am the chair of the Community Engagement Committee, bringing you Therapy Thursday. This is our way to really go ahead and reach back out to the community and provide some information and really talk about some topics that have been um, asked to be shared so we can divulge some knowledge onto everybody and really help out where we can. It's been very difficult in this time of COVID to really be out there in person, hands-on doing what we do. So this series is a way for us to help bridge that gap. Couple of points of order before we get going today. I'm going to put into the chat shortly a couple of different links. One is for our Facebook page. Please go ahead and like our Facebook page. You'll be able to find information there about upcoming events and events such as this one, other Therapy Thursdays, and some other good information on PT in general. And then I'm also going to put our YouTube channel in link in the chat as well, where you'll be able to find all of our past episodes of Therapy Thursday, and you can watch them at your convenience and share them with your friends, family, neighbors, and pets, I'm sure it'll be applicable there too. So, without further ado, for today, our Therapy Thursday is going to be Mythbusters, Knee Arthritis Edition. I'm very pleased to present this topic here today and turn it over to my friend and colleague Carla Hill, who has some wonderful information to impart onto you today. Carla, take it away.
All right. Thanks, Evan. Hello, everyone. I've been a physical therapist for almost 20 years, and I specialize in orthopedic and geriatric physical therapy. I've been with UNC at the Northwest Cary location for about 6 years, and I love it here. I love working with patients and helping them to better understand what conditions they have, help them to know of all the information that's out there, what's accurate, not accurate, how we can help them move better and enjoy life more. And one of the areas that I have a little more experience in is knee arthritis. I collaborate with some researchers at the Thurston Arthritis Research Center. And so when the New York Times put out an article recently that I felt misconveyed a research trial outcome about strength training for knee arthritis, I felt compelled to put together a presentation to try to help dispel some of the things that were being said related to that trial, but also just more general knee arthritis, what can be done to help, not help, and that sort of stuff. So here are the learning objectives today. I hope everyone will get some basic understanding of knee anatomy and common changes with osteoarthritis, what the risk factors are, and of those, what they can have a change in. Discuss the symptoms as well as some common myths about knee arthritis and treatments available, which I'll support with evidence. And then also hopefully give you the information you need to know what might be your next step for management if you have knee arthritis. So why knee arthritis? This diagram shows you the number of people diagnosed and then projected to increase over the upcoming decades in terms of the general population. So currently, this data was done back in 2015, and it predicted in 2020 that we would have 63 million people that have arthritis. So it's a very common condition. And then here are some geographical data points about it. So the data from 2015 shows for North Carolina, we have somewhere in the range of the mid 20% of having arthritis in the adults, so 18 plus population. And then in the lower right corner, of those that have arthritis, the percent that said that they had severe joint pain because they had arthritis. So in North Carolina, that's 30 to 35% of the people with arthritis reported that they had severe joint pain. It also can inhibit their ability to participate in activities. So in the upper left, you see that in North Carolina, 54 to 60% of individuals that have arthritis reported that they had activity limitations because of that. And then in the lower right, some of those activity limitations and pain then evolve into limitations to do their work, which can have a significant impact on someone's life. And that's around 50% of people that have arthritis have work limitations. So this is a big issue. It affects a lot of people, and there's a lot of different information out there about what to do and not to do to try to maximize your ability to be active while minimizing the pain you might experience while doing so. And hopefully this presentation will give you all a little bit more information on what to do. So a little bit of anatomy lesson here that's important for our conversation. So we have the quadricep muscle is in the front of the thigh. It's 4 muscles that act as one to extend or straighten the knee. So they attach to the patella, which is the small round bone on the front. We know it commonly as the kneecap. And then the patella tendon attaches from the patella to the tibia. And so when we talk about knee arthritis, it's talking about this joint space where the femur, the thigh bone, is in contact with the top of the tibia or the shin bone. And it also includes the joint behind the patella or kneecap where it contacts the femur or the thigh bone. We have a couple of different kinds of cartilage in our knee joint. So one is the articular cartilage, and that's the smooth and thin layer of cartilage that lies directly over the ends of the bones. So underneath or on the bottom side of the femur, on the top side of the tibia, and on the back side of the patella, we have this articular cartilage. The second type of cartilage in the knee is the meniscus. And we have a medial or inside, and then a lateral or outside meniscus. And these are a little bit more of a shock absorbing kind of cartilage. They're thicker on the outside edges of the knee and thinner on the inside, and can have a tear in them as the femur and tibia contact each other with various activities and with pivoting and things like that. You can get a pinch of the meniscus, and then as the bones rotate or bend more, can result in a tear of a meniscus. And so those are the main things that we'll want to talk about going forward in terms of what are some of the changes that happen with osteoarthritis. So, and I should have said this at the beginning, but we're specifically talking about osteoarthritis. There are other types of arthritis, but with osteoarthritis, it's usually affects a single joint at a time. It's not necessarily, you can have multiple joints that have osteoarthritis, but it's not a systemic or widespread inflammatory arthritis issue. It affects just a localized joint here or there, and the knee being the most common location for knee osteoarthritis. So how does that affect the knee anatomy that we just talked about? So on the left picture here, again, that's the normal knee with the patella removed, just for simplicity's sake. And then on the right, you see some of the anatomical changes that happen with arthritis. So that smooth, thin cartilage layer of articular cartilage will oftentimes start to get cracks or crevices in it. That reduces the ability for those two joint surfaces to glide nice and smooth on each other. Another thing with the articular cartilage is that it doesn't have nerve endings. So when a cartilage covered bone touches another one, you don't really get that sense of pressure or pain or anything like that. However, with osteoarthritis, and you have those cracks and crevices and it starts to expose the bone underneath, that does have nerve endings. And that's part of why people start to have pain with osteoarthritis. Another change with the bone is you get bone spurs, technically called osteophytes. And these are little localized areas of overgrowth of the bone. And then osteoarthritis can also cause changes to the synovium, which is the lining of the joint capsule. So it's not really pictured on these anatomy pictures, but you can think of the bone to bone area being covered or enclosed inside kind of like a balloon, right? So there's this covering that makes it a completely encapsulated joint space so that there can be the synovial fluid, which helps to lubricate and allow that movement to happen. Some other things that often happen with osteoarthritis is the ligaments can get lax or have more give to them. And then often it also affects the muscles. They tend to get weaker, and in part because it hurts to move or it's harder to move, people don't move as much, and then they end up losing strength. So how is it diagnosed? There are a couple of ways based on the American College of Rheumatology to specify how they decide if somebody has knee osteoarthritis. So it could be just from their history and their physical exam. So if you have pain in the knee and 3 of the following items on the left, then the doctor could diagnose you as having knee arthritis. Alternately, they could use some combination of a physical exam and findings on an X-ray. So pain in the knee plus just one of the following items and have bone spurs seen on an X-ray. So this is what an X-ray might look like. On the left, you see the normal knee joint that has some dark area between the bottom of the femur and the top of the tibia. That's because you should have normal space between the joint there, and cartilage doesn't show up that well on X-ray. And so you see a wider gap. But as the cartilage decreases over time and you develop osteoarthritis, then you'll see less joint space like you do on the right picture here. You can see there's not a lot of space, especially on the lateral compartment, which is the left side. There's also some overgrowth of the bones instead of the nice, smooth, round edges of the bottom of the femur. There's some extra bumps there. So those would be the osteophytes or bone spurs. So this is what a knee with osteoarthritis would look like on X-ray in a pretty severe case of knee arthritis. So just very quickly, I wanted to just let people know that there are grading scales. One, Kellgren-Lawrence grading scale is what radiologists and physicians will use to say how bad of knee arthritis you have. And so it goes from grade 1 to grade 4. And grade 4 is where they'll usually call it bone on bone. So you might have heard that term. And so it's a gradual decline of that available joint space and how much of the knee, the bone spurs that they can see on there that helps them to determine what grade you're at. Generally, they'll call grade 2 and grade 3 is where a lot of people are at and where they might be more likely to start having some symptoms. And at grade 1, most people probably don't even know that they have it. Risk factors of developing Neoa: older age, female gender tends to have osteoarthritis more, obesity, which is the most important modifiable factor. If you can decrease your weight by 5%, that can make a significant impact on knee pain, is what the research shows. So if you're overweight or obese, even a small reduction in your body weight can have a significant impact on your knee pain and then allow you to be more active. So it's kind of a positive cycle. Make a little bit of change, you start to be able to do a little bit more and feel a little bit better, and that's going to encourage you to then continue on with that cycle. Another risk factor is a prior knee injury. So that could be a trauma or sports related. And they found that about 50% of people will start to develop OA changes in their knee within 5 to 15 years after ACL tear. And that's regardless of whether their ACL gets repaired or not. They're doing a lot of research studies on this now to figure out, is there anything they can do to decrease this risk? But thus far, they feel like it's that actual initial trauma to the knee joint when the ACL is torn that starts the path down the course to then developing OA. But hopefully new research will help us to figure out a way to kind of prevent that from happening. Occupation or elite level athlete with high stress on knee joint. So that's if it causes, or they have to do prolonged kneeling or squatting or repetitive impact. And I want to emphasize that it's in that elite level athlete. We'll talk a little bit later about, how much sporting activity is okay and how much will increase your risk. But generally speaking, it's the individuals that are really pushing their bodies many hours of the day, many years, that are going to increase their risk factors with this. And then genetics. So common symptoms would be pain, which can go from mild to intense, and the pattern is usually that it gets worse over time. Stiffness, that's worse first thing in the morning or after somebody's been stationary. So I've been sitting at the computer for a couple hours and my knee hurts and I can't get it moving as well. Or after the car trip, it's hard to get out of the car because it's stiff and painful. Those are things that we often hear. Crepitus is our fancy word for joint noises, which could be described as like a crunching, a popping, or a cracking. And you can also feel it, like if you place the top of your hand over the patella and then you straighten and bend your knee, sometimes you'll feel kind of like a rough kind of grinding sensation under your hand. That's the crepitus, and there's nothing we can do about it. So just know that that's just a normal part of knowing that something's happening in the knee. It's showing some signs of change on the joint surfaces, but we don't really try to alter that at all. Joint swelling, bony enlargement, loss of joint motion, and also limited tolerance for standing or walking are the common symptoms that we see in the clinic. All right, so now on to myths versus facts. So I'm going to present a couple of statements, that I hear from patients in the clinic and talk about what the evidence really says about them. All right, so the x-ray showed I have knee arthritis, so I'm doomed to a life of pain and limited activity. Okay, so here's one study that busts that myth. So a quick statement, systematic reviews and meta-analysis are kind of the highest tier of research. And what they do is they do a really thorough search of all the research that's been published already and narrow it down and summarize it. So whereas a single trial gives us evidence at one level, a systematic review looks at the evidence over many trials and helps us to understand, was this maybe just a one-time thing, maybe a fluke, or is this a consistent pattern that we see that we can rely upon? And so this study shows that there is discordance between clinical symptoms and radiographic findings or x-ray findings. So in those with knee pain found to have osteoarthritis ranged from 15 to 76%, and in those that had findings of OA on the x-ray, the number that had pain ranged from 15 to 81%, right? So that's a really broad range. It means knee pain is an imprecise marker of radiographic knee arthritis, and radiographic knee arthritis is likewise an imprecise guide to the likelihood that knee pain or disability will be present, okay? So the x-ray doesn't tell us that you're gonna have a lot of pain or not. And then here's another study. So This is with the Kellgren-Lawrence grade 4. So remember, that's the worst stage. That's the bone-on-bone stage. And they looked at the data that came from 3 separate study populations. That's what that first line indicates. So we're talking about 15,000 subjects here. They found that pain was absent in 23, 31, and 6% of those subject populations, even though they had grade 4, quote, bone-on-bone arthritis. The WOMAC score, so that is a specific questionnaire that patients can respond to. That's utilized a lot in research and in the clinic to help us understand how bad somebody's pain and function is, was not significantly different between those that had arthritis, advanced arthritis, and without arthritis if they didn't have pain. So the study showed that a considerable number of subjects with Kellgren-Lawrence grade 4 or bone-on-bone arthritis did not report pain. Okay, so again, your x-ray is one thing to consider. It gives us a snapshot of what the anatomy is inside the joint, but it doesn't dictate that you're going to have a lot of pain or not. So while PT or exercise in general might not be able to change your anatomy, know that we might be able to reduce your pain, because people can have bad anatomy and still not have much pain. Next myth, knee arthritis is due to wear and tear. If I do too much activity, I'll wear my knee out. So I have a couple studies that came out of the Journal of Orthopedic and Sports Physical Therapy. This one talked about osteoarthritis of the hip and the knee, and the benefits of exercise in people that have OA. It's supported by high quality evidence that underlines it should be part of first line treatment of clinical practice, and it's not associated with serious risk. So it's a safe option to start treating the symptoms of knee arthritis, and the likelihood of making things worse is minimal. It's also important to know that osteoarthritis is associated with many chronic comorbidities, such as type 2 diabetes, cardiovascular disease, and dementia. And that physical activity and exercise can not just improve the OA, but also the chance of having these comorbidities, or how those comorbidities will be manifested in the individual, how many side effects or negative health consequences they'll have if they have those other chronic conditions. So this came from that same article. This is the journal's, what they call perspectives for patients. And so basically it summarizes the finding of that article in a manner that's easily digestible and understandable to everybody. So that article, I was just reading the summary from, it summarized 96 articles that were looking at the benefits and risk factors of a negative outcome for doing exercise in hip and knee OA. And participating in regular physical activity and exercise often results in better outcomes than medications, injection, and surgery. So they offer 7 key recommendations that it should be tailored to an individual's needs and preferences. Water exercise is a good alternative if you can't tolerate land. Supervised exercise therapy over a 6-week period of time is often helpful to get you started. That's what physical therapy is here for. If you're not sure what to do, you've tried some things and they've hurt, you want some guidance and some specific exercise recommendations for you, physical therapy is a great place to start. Some people need 12 weeks of supervised therapy. Sometimes people will go back for a booster session. So I often finish one episode of physical therapy and say, I hope to not have to see you again, but if something changes, if something gets worse, we need to adapt the exercise that you have, please come back to see me again. And so we can always adapt things to whatever the person needs at the time. Home exercises should be continued, whether it's at home, it's at the gym, it's at the pool, that doesn't really matter. The idea is that even once you finish your supervised exercise sessions, it's important that you keep doing it. If you don't keep doing it, you won't continue to have the benefit of it. And then be sure you understand how to manage flare-up. And that's, again, information that your physical therapist can provide to you. Okay, and here's the second article related to, you don't want to wear your knee out. So this looked at, here's a systematic review and meta-analysis, looking at knee and hip osteoarthritis between a sedentary population, recreational runners, and competitive running. So recreational runners had a lower occurrence of OA compared to competitive runners and controls. And what they called, they basically said, when they say competitive, they don't mean I sign up and I run 5Ks and 10Ks and marathons occasionally. Their definition for competitive runner was a professional, the elite runner, the runners that are running all the time, and really putting their knee under that, compressive factor many more miles than what they consider as recreational runners. They found the more sedentary lifestyle or that really high volume, high intensity running is associated with increased hip or knee OA. So I love this little graphic here, right? You can be a non-runner or a competitive runner and have a 10+% chance of osteoarthritis. But if you're just a recreational runner, which again, that's that broad term, right? The people running, just occasionally or running regularly for years, but not at that elite level, their chance is 3.5%. So you're not going to wear your knee out by participating in reasonable amounts of physical activity. All right, the knee MRI showed arthritis and or meniscus tear or just degeneration. So I'm going to need surgery to fix this. All right, this study looking at MRI findings in asymptomatic adults. So those that at the time they were getting the MRI done, they hadn't had some kind of knee injury and they're not having any knee symptoms, okay, no knee pain. And they found cartilage defects in those under 40 years of age to be 11% of the MRIs. In above 40 years, 43% had a cartilage defect. Meniscus tears, under 40, 4%, over 40, 19%. Bone marrow lesions and osteophytes, that's the bone spurs, was 18% for under 40, 25% for over 40. So MRI osteoarthritis feature prevalence among asymptomatic, no pain, uninjured knees were 4 to 14% in adults under 40 and 19 to 43% in adults over 40. Okay, so this study, again, it emphasizes the fact that you can have an abnormal MRI and actually be totally normal and not have pain. So MRIs and x-rays are great to give us that visual of what the anatomy is, but doesn't determine whether or not you're going to have symptoms or how high your symptoms are going to be. And then this looked at surgery versus physical therapy for meniscus tear and arthritis. So they took symptomatic patients that were 45 and older that had a meniscus tear and mild to moderate osteoarthritis. They were split into either going to surgery and post-op PT or to a conservative route of just a physical therapy regimen. They were allowed at any point to cross over from the PT assigned group to the surgical group if they felt like their pain was too much and they couldn't tolerate it and wait till the end of the trial. And then they measured the physical function score on that WOMAC. So they did not find any significant difference in the physical function score between the group that did the surgery to address the meniscus tear and arthritis versus the group that did just physical therapy. So if you can, however, they did have 30% of patients assigned to PT that decided to undergo surgery before the end of the trial. So if your pain is not that bad that you cannot tolerate doing your physical therapy regimen, and you're willing to commit to doing that consistently, then you don't need to have surgery to still have equal functional outcome a year out from the time that you're having the symptoms. And one final one related to this, here is the Australian Knee Society Arthroscopic Surgery Guideline. that says arthroscopic debridement and or lavage has been shown to have no beneficial effect on natural history osteoarthritis and should not be the primary treatment. Partial meniscectomy, so that's where they just go in and they clip out a little part of the meniscus, the part that has the tear, is not indicated as an initial treatment for atraumatic tears. So the atraumatic being, without a specific trauma or cause to it, you're having knee pain, they do an image, they find that there's a meniscus tear, you don't necessarily need to just go get it clipped out. In fact, doing so will increase your risk for developing arthritis down the road because you've removed some of the cartilage. So if you can tolerate a physical therapy regimen, it can make you equally functional and hopefully help you not have an increased risk of arthritis in the future and help you have good function at that time. Now, that being said, there are certain times, as it says here, where it would be indicated to go ahead and move forward with the surgery. If there's true locking, if there's certain types of tears, and that's where the orthopedic surgeon should help you to decide. But if it's just kind of a straightforward, you're having some knee pain and the image shows some osteoarthritis without mechanical issue, as we call it, then try exercise and physical therapy first. All right, and then the last myth I have, the news recently reported that a study for knee arthritis showed no improvement after knee strengthening. So there's no reason to exercise if I have arthritis. So this is the article that I mentioned that kind of made me say, wait a minute, I need to get out there and make sure that we're not letting people live with myths in their mind about knee arthritis and how they can manage it. So the trial is over here on the left, was published in JAMA, effective high-intensity strength training on knee pain, knee joint compressive forces among adults with osteoarthritis, the START trial, out of Wake Forest. And then it led to the New York Times article with the headline, "Intense Strength Training Does Not Ease Knee Pain Study Finds. Millions of patients with knee osteoarthritis are told to exercise, but new study cast doubt on what sort of exercise is helpful." And interestingly, I actually talked to Dr. Loser about this recently, just to make sure that what I was reading and how I interpreted it was accurate. And he agreed. One of the first things he says is he felt that mainstream media had kind of misinterpreted what were the most valuable findings out of the study, and that in no way is meant to imply that exercise is not helpful for those with knee arthritis. But their conclusions you can see here on the right. They had 3 groups. One did what they called high intensity strength training. So they used a set of machines in a fitness facility and made sure that they were having to lift enough weight that it was high intensity. The second group did low, or really what we would call moderate intensity. And then the final, they called an intention control. So in research studies, there can be a disproportionate amount of attention that the different participants get. So if you have a true control group that gets nothing over the course of a year, they know they're getting nothing, right? And just giving them some attention can try to help to level out some of the groups, okay? So they did what they called an intention control group here, but that group got more than several sessions of health information during that time frame. And we're going to talk just a little bit more about what this study really does tell us and doesn't tell us. So what it did find, that high intensity strength training was not better than low intensity strength training or the control, which was actually bi-monthly to monthly health education sessions, not specifically about knee arthritis, but about healthy behaviors and how to be healthy and things like that. So there was no difference among the 3 groups for knee pain, knee compression forces, or functional status at the endpoint. However, the control group had a 30% reduction in pain, and they had reported that they were increasing their physical activity on their own. So their participation in the trial wasn't making them increase their physical activity, but because they were attending these health education sessions, they then on their own increased their physical activity. So is it really fair to say that the control group should not have had an improvement compared to the strengthening groups when they were also doing physical activity or exercise of some kind? And that 30% reduction in pain greatly exceeds what their typical control response is, which from prior trials showed 15% or less reduction in pain for that control group. It also did show us that all three groups had some improvement in their measures across time. And also something that may have impacted it is that they had mild and low disability at the start point. So was there much room for them to really show a big difference among the different groups because they did different things? All the groups had what they called responders, meaning they had at least a 20% reduction in their pain. And among the three groups, it was anywhere from 45 to 60% of the people in a given group were responders. So at least half the people, regardless of, you know, which of the three things they did, had a good reduction in pain, and then they had decreased use of medication. What it did not tell us that high or low intensity strength training is harmful to participants. Both of these interventions are safe for people that have osteoarthritis. That sedentary behavior is as good as exercise. That is not true because the controls became physically active over the duration of the trial as well. That high intensity strength training leads to faster progression of arthritis. So one of the other things they monitored is how much joint space they had on x-ray at the beginning and the end of the trial. And they found that the high intensity strength training group didn't have any more loss. So one of the questions going in is, if you're loading the knee with a lot of weight with the high intensity strength training, you know, does that maybe progress the loss of joint space? And that was not true. And that individuals with knee arthritis shouldn't exercise. And so the take-home point, individuals with knee arthritis need to exercise, but they have some freedom in choosing the type of exercise that they prefer to do, that they'll enjoy doing and doing consistently to get the greatest benefit. And then the last couple of slides are from the American College of Rheumatology. They put out guidelines. And so, like a systematic review, they do extensive review of all the articles, all the individual trials that looked at the population of interest and whatever variety of interventions they tried. And then they try to summarize it. So on this page, the dark green are what they strongly recommend. There's many trials that have been done on that intervention and have shown some benefit. Some benefit is smaller gains than others, but they've been beneficial, and they have a lower risk of side effects if they're not helpful. So you see exercises at the top of the list for people that have hand, knee, or hip arthritis. Weight loss is also important for the lower extremity arthritis joints. And then there's other items that you see here. Again, this emphasizes what that previous article said about needing to have physical activity that's tailored to your preferences so that you continue to exercise. And you may need guidance on what those exercises can and should be to get you started on a good program. And then in that same article, they also had the ones that they were strongly against or conditionally against. And so they're against it either because there have been trials and it showed no benefit or increased harm in order to do it, or the trials did not have appropriate rigor, which means they were very biased. So even if they showed benefit, they felt that the trial was not of high enough quality to base recommendations that they should do it. That there's reason to think that the outcomes that they're sharing is not of high enough quality to recommend those things. And then conditionally against, generally speaking, those are things that maybe just don't have enough evidence yet. There weren't enough trials that specifically looked at it. or the trials that did look at it didn't show really enough benefit to feel like it should really be part of that first line treatment management. All right, so I know I'm about out of time here, but hopefully that was a lot of valuable information for you, and I'm happy to take questions.
Carla, that was great. Just really, really informative. I know as a clinician myself, that was really helpful for me to have that information to pass along to my patients. I work with a lot of runners, and I was putting in the chat there that it's very comforting to me now that I can really have more evidence-based reasoning to say running is not bad for you. I always tell my patients that, okay, well, bad running is bad for you, but running itself is not detrimental to your joint health. So it's nice to have a little backup on that. We do have a question in the chat there. Do you have any comments on the benefits of anti-inflammatory diet on Neoa?
Yeah, so I will say that the nutritional side of things is beyond my usual practice. They do know that knee arthritis has some inflammatory components to it, even in the pre-development stage. So in the really early, where you hardly see anything on the imaging, when they look at pulling out synovial fluid from the area, that it shows some inflammatory markers early on. And so it seems to make sense, but I haven't done enough research in it myself to say, well, then you definitely should do the pro-inflammatory diet. When patients start asking me those things, I refer them to one of our dietitians here to help them to really try to tease out what foods they're eating and help them know, are there either some supplements or foods that they can increase or decrease to try to change that inflammatory balance.
Great. I think we have time for maybe one or two quick questions here. One question was, are there any exercises in particular that are not recommended in patients with Neoa? It's kind of
I don't think that there's really any hard and fast. I think if you have higher grade Neoa, you're at the higher end spectrum of less joint space. I would advise, to consider how you actually feel during and after performance of, say, plyometric exercises. We know that that's going to increase the load the greatest when you land from any kind of a jump scenario. So if you're more symptomatic or you have more changes, then I would shy away from some of those things and encourage more of a low impact thing. But there are certainly ways that you can be intense with low impact activities. So I try to help make sure people understand, just because we modify what activity you do doesn't mean you can't still feel like you get a good, strong workout out of it.
great. And then the last question we kind of had there was, what is it about Tai Chi that works well for Neoa?
Yeah, so that's really interesting. There's been quite a few studies out there that have shown it's been beneficial. And so one of the things I didn't get into today, but we know that individuals that have Neoa have about a 30% increase in falls risk. And Tai Chi has had a lot of benefit in individuals in reducing falls risk. And so it's a slow motion exercise movement. And so people don't necessarily think of it as exercise in the traditional form, because you don't necessarily work up a sweat or elevate your heart rate to the same level, but you are working on your balance. You're working on what we call motor control, how the different muscles contract and relax to work together to create movements. And it also is relaxation. So if somebody's, higher stress, we know that that can increase pain response in general. And so if Tai Chi helps to kind of calm them down, calm the system down, that can also have a benefit just on pain in general.
Great. I think that's where we have to wrap it up here for today. I do see there was one more question on here about glucosamine. Surprised that was strongly against. I would agree. I don't know the reason for that either. But unfortunately, we have to kind of wrap things up here, let everybody get back to work. If you have other questions, please head over to our Facebook page and you can send us a message there. Also, I'd encourage you to sign up there and on our YouTube page, and you'll find out about more events coming up. Our next Therapy Thursday will be on May 6th. I don't remember the topic offhand, but it will be at the same link that you used to get here. You'll find out more information as it's posted on our Facebook page. Thank you, Carla, so much for a wonderful presentation. Great, excellent information. Thank you, everybody, for attending, and we'll see you all in a few weeks. Okay, have a good rest of your week. Bye.
Thanks, everyone.